Hey, everybody. Good morning. Welcome to day 2 of the MCBK meeting, our public meeting. We had a great day yesterday. Just some wonderful speakers, wonderful questions, terrific attendance, very few technical difficulties. These things these are par for the course, but Chuck and I are really pleased with how it went. And so thank you all for joining us again for day 2. As we get started here, I just wanted to make a couple of announcements. First, I mentioned we had great participation yesterday, and we did. We had 195 participants, including folks from China, India, UK, Saudi Arabia, and of course, the United States. The poster session, the lightning poster session was terrific. It was a lot of fun to see 1-minute presentations of 26 different platforms and demonstrations of CBK in action. And then we had an evening poster session that went very well as well. We had some lively discussion. In terms of our day-to-day, let me give you a quick overview before I turn it over to Chuck and move us forward. Let's see. So we're going to have an opening plenary on state of the movement and related movements. And we've got some speakers from the UK to join us. And we've also got Steve Bernstein from the ACE program, the AHRQ ACE program. We then have a panel on stakeholder engagement in MCBK with Michael Fitz and Sally Oken. And then we'll have a break, and then we'll move into our work groups action session, breakout session for almost 2.5 hours to dig into these specific areas. Remember, there's standards, policy, sustainability and inclusion, and technical infrastructure. So we encourage you to pick one group and go. You can hop around groups a little bit, but I think it'll be great to sort of dig into one group and see how they delve into some of these MCBK issues. And then after that, we'll have a very brief closing session, just some comments, remarks, and next steps. And then we'll have a Zoom social hour and invite anyone that cares to join us from 4 to 5 today. Share your feedback, comments. It'll be very informal and casual. So I hope you can join us. And we do thank you for all your attendance and engagement day 1, and looking forward to kicking off a wonderful day 2 with some terrific speakers and discussion. So with that, I'm going to move to my colleague, Chuck, who needs no introduction, but I will give him a brief introduction nonetheless. He is the visionary and starter of the MCBK effort, as many of you know, and we've been working together for a number of years on this. Chuck is the Josiah Macy Jr. Professor of Medical Education and the chair of the Department of Learning Health Sciences at the University of Michigan Medical School, and also the editor-in-chief of Learning Health Systems Journal. So Chuck, will you say a few words about the state of the movement, and then I will introduce our other speakers on the panel.
Sure, Rachel. Thank you so much. It's really a pleasure to have a chance to speak about the movement. And I'm very excited about the progress we've made. And just echoing something that Rachel said, I'm extremely excited about our meeting yesterday. The participation was superb, and it all in all, I think it was a wonderful day yesterday. And I hope you all feel the same way. Welcome back. So you saw this slide yesterday, and I want to return to it as a point of departure from my very brief remarks this morning. MCBK is a multi-stakeholder movement to mobilize computable biomedical knowledge, and I want to emphasize multi-stakeholder, and in a way preview the session following this one, which really is going to explore what we mean by a multi-stakeholder movement, and maybe challenge us to make MCBK more multi-stakeholder than it has been in the past. The interim home for MCBK is the University of Michigan, and more specifically, the Department of Learning Health Sciences at the University of Michigan. And there is some question about, as we think about the state of the movement, whether that should be the home of the movement going forward, or whether we should begin to think about a new home for the movement. We're fine for the moment. But the future is something we should be exploring. We have a terrific steering committee, and I'll show you the names of the people on the steering committee in a moment, who are providing guidance for MCBK. Our mission and vision are expressed in a manifesto, which, amplifying on a comment that Rachel made yesterday, is a consensus document that reached consensus at our first annual open meeting in 2018. And the manifesto that is published on our website reflects the consensus of the participants at that meeting, and some discussion among those participants that took place after that. Our website, containing a wealth of information about computable knowledge and the movement, is mobilizecbk.org. Our activities to date include an invitational organizing meeting that took place, 3 years ago, it seems like yesterday. 2 annual open meetings that we were very pleased were co-sponsored with MCBK by the National Library of Medicine. These took place on the NIH campus in the summers of 2018 and 19. As Rachel just said, we had 4 work groups. We have 4 work groups, and those work groups' activities, products, deliverables, and future activities will be the foci of the parallel sessions that will take up much of the afternoon's activities at this meeting. We have web resources accessible through the website higher on the slide. We have hosted several webinars, and we are delighted, as you will hear in this session, with our emerging global collaborations, as well as our collaborations with other organizations in the US. Now, if you are asked, and many people ask me this question, what are the key differentiators of MCBK? Where do you fit in to this enormous and dynamic ecosystem of knowledge and data in the world of biomedicine? I would argue that there were really 3. The first is a focus on computable knowledge. This builds on the definition of knowledge that I offered in my opening talk yesterday, viewing knowledge as a result of an analytical and/or deliberative process with significance for an identified community. And it also emphasizes that we are talking about expressing that knowledge in machine executable forms, i.e. in code, complementing human readable versions of that same knowledge. Differentiator number 2, and I mentioned this yesterday in my talk, but it is a key differentiator, and that is that MCBK spans these 4 domains of health and biomedicine. We believe that computable knowledge is equally applicable to healthcare, public health, research, and education. We have a wonderful webinar on 4 use cases spanning and addressing these 4 domains on our website. And if you really want to hear how MCBK applies in detail to each of these domains, I would encourage you to take a look at this webinar. And finally, last but certainly not least, in my view, is the explicit relationship of MCBK to the concept of learning health systems that are capable of mass action, and in fact, in my view, only capable of mass action if the knowledge that drives improvement is expressed in computer readable and machine executable forms. Corollary to this, and very close to the concept of learning health systems, is also this idea of inclusion of all stakeholders. And this is very clearly expressed in the core values of learning health systems, as I think you will hear in the next session. Here is our manifesto. Rachel showed this to you yesterday. I encourage you to look at it and read it. I have it memorized. I'm not asking you to memorize it, but I think it would be great to always keep this manifesto in mind as you think about what MCBK is doing. Here is a quick view of our excellent steering committee, which does include all of the co-chairs of our 4 working groups, in addition to several others who have selflessly volunteered and contributed their time to advancing MCBK, and we would not be anywhere near where we are today without them. So recent and planned developments. MCBK is going global. The first global manifestation you will hear about in just a moment, and it's the MCBK UK initiative. There is also very specific interest in MCBK in China and in Australia, and I believe in other countries as well. So MCBK is very much going global. We are developing a relationship between MCBK and the Learning Health Systems Journal. The poster abstracts, as we mentioned yesterday, will all be published as peer-reviewed abstracts in Learning Health Systems. And Learning Health Systems, as you might know, has begun an adventure to publish computable knowledge as peer-reviewed computable knowledge. And we are continuing to develop this idea as the journal matures, and you will be hearing more about that. And finally, we are building relationships with many entities with similar interests, trying to understand what exactly the niche is for MCBK in this ecosystem, how to take maximum advantage of it, and how to synergize MCBK with other efforts with related goals and aspirations. The steering committee will be meeting, I think it's actually on July 6th, and that's a typo, to ponder and explore the future of MCBK in a way that is very much informed by what transpires at this meeting. The steering committee will be thinking about what exactly MCBK should be in the long term. What are we trying to do, and whom are we trying to serve? We will be considering our future organizational home, as I mentioned before, our relationships to other entities, how to bring in all stakeholders, and whether MCBK can and should remain, as it has been in the past, primarily a volunteer organization. I cannot tell you how many people have, beyond the steering committee, volunteered their time in service to the goals of MCBK. So that completes my remarks, and now I will turn things over back to Rachel to continue and complete this session with our other speakers. Rachel, thank you very much.
Wonderful. Thank you, Chuck. This is great. You can see the slide now with the rest of our speakers for this panel, and we will allot some time for questions at the end. So first, in our next session here, we have a duo from the United Kingdom, and thank you for joining us at this late hour. Philip Scott and Jeremy Wyatt are the co-leaders of the MCBK UK community. Philip Scott is a reader in health informatics at the University of Portsmouth and digital healthcare architect at Portsmouth Hospital's National Health Service Trust. He is deputy editor of BMJ Health and Care Informatics, serves on the boards of Professional Records Standards Body and the HL7, Health Level 7 UK, and is chair of the European Federation for Medical Informatics Evaluation Working Group. Philip has worked in health and care informatics for over 20 years. And Professor Jeremy Wyatt is an emeritus professor of digital healthcare and former director of Wessex Institute and clinical advisor on new technologies to Royal College of Physicians. His research uses empirical methods to uncover scientific principles guiding the design of clinical information and e-health systems, studying interactive tools to change the behavior of clinicians, patients, and the public, and also of digital tools to support health research. He was UK's first elected fellow of the American College of Medical Informatics in 1997. So welcome to you both. Thank you for joining us. And Philip, I'll turn it over to you to start.
Thank you very much. So it's a pleasure to be with you and enjoying a great conference. So thank you, Chuck and Rachel, for the introduction and the opportunity to speak to you today. So as has been said, we are co-chairing the MCBK UK activity. And so we just wanted to give you a quick outline of how we've been doing that and what the progress so far has been. So we're going to introduce who's been active, what is the community that has come together to support the CBK agenda, describe particularly the inaugural meeting that we had last year, and then Jeremy will go on to talk about one of our future projects, a partnership with Health Data Research UK, and some of our other future plans. So first of all, who's who? Who are the active participants? So I'm there representing BCS, formerly known as British Computer Society, the Chartered Institute for IT, and particularly the Health and Care Specialist Group. The other leading organisation is the Faculty of Clinical Informatics, who've provided the administrative support and helped with the logistics and particularly getting our meeting set up. And then in addition to BCS and FCI, we've also had great support from NICE, the National Institute for Health and Care Excellence, NHS Health Education England, particularly their knowledge and library services, as well as HR7 UK, and as already mentioned, Health Data Research UK. So there's a great many other organisations, but I think it's fair to say these are probably the core members of our coalition. So we held our first meeting in October in London, and we had an invited audience. The room was completely full with 65 in attendance. We were pleased to be able to have an introductory talk by the technical advisor for the Secretary of State for Health in England, who at that time was also the Chief Technology Officer for NHSX, the latest central body for NHS IT. We're not going to look at it now, but there is a link which you can see in the slides there to the videos. All the presentations were recorded, and that's freely available on YouTube. So the group that came together for that meeting, initially we were simply an event steering group, but we all felt that there was an important program of activity that needed to be coordinated. And so we then formulated this into a joint working group between BCS and FCI. And Jeremy and I are the co-chairs of that group. So based on the survey we did of invited attendees for that inaugural meeting, this is how it breaks down. So I don't know how well the colours come through, but we had just over a fifth were academic, just over a fifth were from commercial suppliers. A large group, about a third, were ALB, that's arm's length body, in other words, government agencies. 22% professional bodies in various ways, and one, which was 2%, was one regulator, the Care Quality Commission. So quite an interesting spread of stakeholders, as Chuck was alluding to, the stakeholder mix of CBK. This was quite interesting about levels of experience. It's kind of a normal distribution with a bit missing. That there was nobody who had no experience at all, and equally at the other end of the spectrum, only one person claimed mainstream use of computable knowledge. A lot of people had talked about it, quite a few exploring it or doing pilot projects, and then a handful, I guess, having routine use in at least part of their organisation. But I suppose the reassuring bit is that no one at all had explored but rejected the idea of computable biomedical knowledge. So there was a kind of a reassurance from that particular gap. We asked people why they thought this was important, and I don't think there's any surprises there. Several references to learning health systems, personalised medicine, integration with EPRs, interoperability of clinical guidelines, rapid implementation, and one person was honest enough to say they're not sure. But clearly a whole set of themes that I think we can all recognise. We also asked about concerns, and again, I don't think there's anything particularly different there. Concerns about perhaps bias, context, complexity, infrastructure, curation, preserving meaning. Again, I think all things that we've seen addressed in various ways through the CBK movement so far, and indeed in the content of this conference. They're a fairly keen group. 46 people responded to this question, asking their level of interest. And as you can see, most of them are at the very positive end of the spectrum. And I think that's been reflected in the the level of support we've had since that inaugural event. And this was my attempt, based on the stakeholder organisations, to kind of position where we are in terms of the spectrum from data through to knowledge, and from technology up to human implementation. And it did seem that the majority of this community are really in the right place. We've got a mix, but we certainly have strengths across the real knowledge end of the spectrum and the real human implementation end of the spectrum. I accept those dimensions are somewhat arbitrary, but it was a means to just kind of get some mental picture of what the community looks like. So in summary, we do have an excellent mix of stakeholders. Most of it is early stage activity with just a few well-established. There is a good awareness of the benefits and the risks, and a willingness to make meaningful contributions. So I'll hand over to Jeremy now, who's going to talk about the partnership with HDR and our future plans.
Thanks, Philip, and thanks, Chuck, and the organising committee for including this in your session today. So I expect most of you are aware of Health Data Research UK. It's emerging as a very significant body in the UK for promoting and facilitating research around the big data in health space. But they've also recently set up a Better Care programme, which essentially is facilitating learning health systems across the UK. And that's called the Better Care programme. There's a link there to find out more. And they have asked us, and we've now contracted with them, to support the internal knowledge management to bring the different learning health systems that they are constructing together to share learning. And in addition, they're very interested in harvesting the actionable clinical knowledge that these learning health systems generate and making it available in computable format for wider use outside of the Better Care programme. So we will be trying to understand what kinds of knowledge they're generating, and there is Philip's already referred to the Health Education England Knowledge Mobilisation Framework. There's a number of tools in that framework that we can use to help this. We're also going to be running a knowledge hackathon to try and get Better Care participants to represent the actionable knowledge they are generating in computable format. And that will then be made available to those people putting together electronic health records as knowledge objects. We're also going to be including some people from NICE. Philip also mentioned that we've had very strong participation from NICE, and they're very keen to work with us to prototype some of these methods. So next slide. This slightly complicated diagram shows what we're trying to do in diagrammatic format. Obviously, we need to be aware of the literature and what's going on elsewhere, but then we'll carry out some user research in the blue box. The Health Data Research are running Insight Days. The first one's on July the 16th, and we'll be there running exercises for participants there. We'll also do surveys and interviews offline. And we'll look at the use of the current knowledge management tool they have, which is something called Health Data Research Gateway, and they're using Discourse on that. And that will help us with the first of our big objectives, which is improving internal knowledge sharing within the community, understanding their tacit knowledge needs, their sharing culture, etc., and then applying some of those methods from Health Education England to support and promote the tools that they already have. And we may, if we have time and resource, be able to audit the use of those tools and see if we've helped them. And then the next objective is to improve the external sharing of actionable knowledge. And for that, we really need to understand what kinds of actionable knowledge Better Care Programme is producing. And we will also, using that audit of their projects and activities, select the participants and case studies for our hack day. We also then need to think about which knowledge tools could be useful to for the hack day, and then that will, and it will almost certainly be more than one of the knowledge tools that are out there. And we need to develop some criteria for that and marketing to do that, but that should be informed by user research. Then we'll convene that clinical knowledge hack day, and that will result in a number of maybe algorithms or symptom sets. For example, we know one Better Care Learning Health Systems developed a symptom set for COVID using some of the large data sets they have access to. So one of those knowledge products might be that COVID symptom set, which could then be used to, for example, populate templates used by primary care practitioners. So as long as the knowledge that we capture is validated, it can then be shared more widely, and we'll try and audit the use of the clinical knowledge tools on the gateway. Again, if we've got the resources to do that. So next slide. In addition to the Knowledge Hack Day, we're also publishing the articles that resulted from BMJ Health and Care Informatics. That's one editorial, and I think 7 articles for it. And I think those will be coming out in the next couple of weeks, so certainly in July. So please look out for those. They're going to be published as a supplement to BMJ Health and Care Informatics to keep them together. We'll be recruiting further collaborators and partners, and we're actively doing that. Obviously, we're delighted to be networking with yourselves in the United States and with other international and national MCBK activities. For example, Chuck and I presented to the International Academy on Health Sciences Informatics in April, and we had some really useful feedback from that, and there's a possibility of a working group ongoing from that. We're going to be arranging further national events like the workshop we had in October, probably virtual events, and seeking further funding to develop demonstrators and support relevant research and development. So that's really just about it for us, I think. And here are our email addresses. Thanks.
Wonderful. Thank you so much for sharing those perspectives and those exciting activities. We do have one question already, and I encourage people to send your questions through the chat, and we might do them now or at the end of our panel. But we do have a question from Ed Hammond. Will globalization be tools and concepts, or do you think we could share computable knowledge? In other words, what is impact of culture, terminology, and practice across country lines?
Good question. Do you want to have a stab at that, or shall I have a go, Jeremy?
I'm happy to respond. Hi, Ed. Thanks for your question. And I think you're absolutely right that we have to be sensitive to local practice and the way that even coded records, the semantics of coded records is often doesn't transfer very well. And we find that in the UK, even from one primary care centre to another, different GPs or groups of general practitioners define and diagnose asthma or hypertension in different ways. And they will use the same codes, but what they mean is different. And that's why I think we're always talking about decision support rather than decision making when this computable knowledge is used in decision support systems, and why this is really very much the start of a journey, and why we need some demonstrators to try and surface how important some of these issues are compared to, for example, technical interoperability with different coded record systems. But thanks very much for that very interesting and challenging point.
Yes, wonderful. Thank you. I'm seeing a number of questions come in. Some I am going to hold for the larger session, but there is one I think in particular would be wonderful for you both to address, and that is the MCBK UK Knowledge Hackathon's focus on COVID-19. Are there any relevant activities there you could comment on?
Well, I think it's a fair guess that there will be some COVID-19 content, because that's where all the wild activity has been going on in recent months, with some great results. I don't think we'll be limiting it to that though. I think the Better Care programme has a fairly broad agenda, albeit a lot of it has been moved into COVID activity, and we do also want to look at existing NICE guidelines. So I think it's fair to say that we don't know what yet, because we're literally only just starting this project this week. it's fair to say, though, there will be COVID content and there will be some other content, and we will be inviting participation as we develop the ideas for the hackathon.
Wonderful, thank you. And that question was from Jerry Osteroff, who also was curious about how that would connect with the activities that'll be described by the next speaker. So I think I'll move into to that portion of the panel, and then I think there'll be some questions that you all can comment on, and Chuck as well. So thank you both for sharing those wonderful talks and taking time out of your evenings and your summer vacations for us. Next on our panel, we're going to hear some U.S. perspectives. Steve Bernstein is Senior Advisor for Digital Healthcare in the Division of Digital Healthcare Research in the Center for Evidence and Practice Improvement at the Agency for Healthcare Research and Quality, which is AHRQ. He directs the AHRQ Evidence-Based Care Transformation Support, or the ACTS initiative. Also, he is Project Officer responsible for multiple clinical informatics grants, contracts, and other health IT initiatives, including evaluating the use of clinical decision support, artificial intelligence, and other tools to improve healthcare. In addition, he's responsible for supporting various websites, knowledge management, and collaborative programs for the nationwide practice-based research networks and the U.S. Health Information Knowledge Base, or USIC. Steve previously served as AHRQ's Chief Information Officer, responsible for agency's enterprise IT initiatives and infrastructure. And prior to working at AHRQ, Steve is a graduate of Cornell University with a degree in engineering and operations research with a focus on computer science. So, Steve?
Thank you, Rachel and Chuck, for the intro, and thanks to all for participating in this session. It's certainly my pleasure to be here with you to talk about ACTS, which, as Rachel, for the AHRQ Evidence-Based Care Transformation Initiative. I'll try to keep this a very short and high-level presentation, less than 15 minutes. So here's the agenda. I'll discuss the ACTS objectives. I'll explain about stakeholder community and work groups that inform building the roadmap. I'll briefly talk about the approach we took. I'll provide a high-level overview of the roadmap. I'll discuss the AHRQ Digital Knowledge Platform and the knowledge ecosystem and learning health system concepts. I'll discuss the benefits we anticipate from implementing the roadmap. And I'll review an ACTS COVID guidance collaborative website and plan pilots. And lastly, I'll discuss the next steps for the ACTS initiative. So AHRQ began the ACTS initiative in late 2018 to determine the requirements and to build a roadmap for an AHRQ digital knowledge platform to improve dissemination and use of AHRQ's resources, to make them more fair, which is findable, accessible, interoperable, and reusable, and also more computable and useful. The high-level goal is to meet the greater need of AHRQ to support practice improvement and transformation, and to have AHRQ's evidence, resources, and tools directly support patients in clinical practice. A key objective is to ensure that AHRQ's digital knowledge platform interoperates seamlessly with other knowledge platforms in the public and private sector. The goal is to improve knowledge creation and knowledge use at the point of care. We want to ensure that this platform is built in the context of a larger knowledge ecosystem, which is we don't want to build the platform as a silo. We want the platform to be properly integrated with the larger ecosystem efforts. And we want to build a stakeholder-informed roadmap to ensure that the platform and the eventual knowledge ecosystem support AHRQ's mission and priorities, and enable creation of learning health systems to achieve the quadruple aim. This slide shows the knowledge ecosystem and learning health system cycle, which directly supports AHRQ's mission. AHRQ's mission is to produce evidence to make healthcare safer, more accessible, equitable, and of higher quality. And to achieve this by working with our partners in the public and private sectors to ensure evidence is better understood and used. The four aims shown in the center of the cycle are to improve health and patient and clinician experiences and to reduce costs. This cycle shows what we want, which is for evidence, knowledge, and data to flow seamlessly around this learning cycle. We want tools and resources for practice improvement and care transformation to easily be put into action at the point of care, when, where, how, and in the format needed. And we want to get outcomes data to learn and ask the right questions and identify the evidence gaps, and to use that feedback to decide on best research to improve creating, disseminating, and using new and better evidence and guidance, which then can seamlessly again go around this learning health system cycle to achieve the quadruple aim. So the approach we took from the beginning was to form a diverse and wide stakeholder community with multiple work groups to produce the roadmap and align it with the other related efforts going on. We formed work groups to evaluate standards, infrastructure, architectures, marketplaces, stakeholders, business needs, and collaborations needed to achieve a learning health system and the quadruple aim. A first key step was to define a stakeholder-driven consensus for the future vision versus the current state. And we defined stakeholder-recommended actions that would be needed in a roadmap to achieve the future vision. And most importantly, this stakeholder community was a totally volunteer effort. The members were fully engaged and interested in supporting this effort over many weekly calls during the past year and a half. Stakeholders were willing to stay engaged because they saw the need for this shared future vision to achieve meaningful and valuable care transformation. And they realized that it was big for any one organization to take on, and that it needed to be a collaborative effort. And the stakeholder community members were willing to give freely and share information and ideas. It definitely seemed that the need for this future vision and collaborative initiative clearly struck a nerve across this community. And just as important, we coordinated with many other key related initiatives. For example, efforts by the MCBK work groups and by CDC's adapting clinical guidelines for the digital age effort, and by AHRQ's various clinical decision support and CDS Connect efforts, and by the MAGIC international efforts, and by HL7's FIRE efforts like evidence-based medicine EDM on FIRE, clinical practice guidelines on FIRE, and also efforts led by Logica Health and by the Object Management Group Business Process Modeling Plus for Health, and by many other activities. The stakeholder community currently consists of approximately 240 individuals. They're from various types of organizations, as shown on these next two slides. For example, care delivery organizations, quality organizations, EHR and CDS vendors, government agencies, researchers, special societies, professional organizations, patient advocates, payers, and others. It's really been a very active group with many involved in contributing and enthusiastically helping inform development of the roadmap. This and the next slide show the breakout of the community. You can see the diversity of members from various EHR vendors and CDS vendors and IT vendors, many members from frontline care delivery organizations and government agencies represented. And there are specialty societies and professional groups and major standards groups like HL7 and others. And here are the road groups that we set up. First, to focus on defining the future vision, and a marketplace for evidence, knowledge, tools, and resources work group, and a standards and infrastructure work group, and a work group to define key concept demonstrations that would have high yield and value, and then having the results from all these work groups feed into a stakeholder-informed roadmap work group. Now, this slide shows a high-level overview of the roadmap. The roadmap objective was to provide a stakeholder plan and pathway for better dissemination and use of evidence and guidance resources to establish a knowledge ecosystem in learning health systems to deliver better healthcare and health outcomes. The roadmap was built as a 10-year plan, bringing together key public and private initiatives with 5 high-level milestones. The first-year milestone is to lay the foundations and requirements for the plan. The next year's milestone is to begin broad implementation pilots. The next milestone, after 3 more years, is to achieve more robust implementation plans towards the future vision. In 7 years from now, the milestone is to achieve better enterprise-wide knowledge discovery and use, which is to realize the fairness objective to achieve the quadruple aim improvements. And the last milestone in 10 years is to deliver a working knowledge ecosystem with evaluation feedback and ongoing learning mechanisms in place, and an effective knowledge supply chain supporting stakeholders' needs. This slide shows the ARC Digital Knowledge Platform proposed by the platform is a key building block to accelerate delivery of the latest evidence to the point of care. It's believed this ARC platform can serve as a catalyst to help establish a national knowledge ecosystem and learning health system to help fix the current very broken knowledge supply chain. This slide shows the cyclical flow of moving research studies into evidence synthesis and then translating a body of evidence into clinical decision support and quality improvement guidance and interventions for dissemination and implementation into clinical practice, and then having a feedback loop to identify questions and evidence gaps and outcomes and performance measures to drive additional research to improve care. Unfortunately, this process doesn't work very effectively or efficiently now. The objective is to make this knowledge supply chain more computable, interoperable, and accessible. To achieve this goal, the roadmap proposes building, as a first step, an ARC digital knowledge platform with an insights engine to make ARC's resources fair and useful. The platform will leverage available standards and a common reference architecture and technology tools, along with a trust framework and governance policies, to seamlessly disseminate and implement evidence and guidance from ARC and others into care. The objective is to deliver the latest knowledge through marketplaces to patients and care teams, to QI teams, to resource developers, and other stakeholder consumers. The end goal is to achieve the quadruple aim and provide performance, quality measures, and other feedback data and outputs to support the learning health system cycle. This slide shows the high-level concept of the knowledge ecosystem. The ecosystem is comprised of a public sector knowledge marketplace, the marketplaces shown on the left side, and commercial sector knowledge marketplaces shown in blue on the right side. The public sector marketplaces are comprised of free and open digital knowledge platforms. For example, the purple rectangle represents the ARC Digital Knowledge Platform that we just displayed on the prior slide. The commercial sector digital platform marketplaces are private and for-profit. Examples are those hosted by the EHR and various CDS service vendors. The reference architecture green layer provides the underlying standards, tools, trust framework, and policies to enable and make all of the resources and tools across the ecosystem fair. The reference architecture also facilitates and enables standardized and cost-effective knowledge creation through the supply chain to better support creation of L1 and L2 human readable evidence and guidance, mostly in paper form and PDFs today, to the creation of L3 and L4 more computable clinical decision and executable interventions. The public-private partnership green layer at the bottom is the organizational structure needed to govern the reference architecture and to respond to and support requirements coming from stakeholders. This slide shows the potential benefits from implementing the ACTS roadmap. Billions of dollars are spent on creating evidence and guidance tools and resources that are not optimally used. There's significant waste from poor information flow, unnecessary and inefficient services. Patients often only get 50% of recommended care, which often results in significant preventable harm. There's significant clinician burnout, which results in low quality care. There are potentially billions of dollars a year that can be saved by recovering waste due to failure to implement best care practices. We believe there is significant evidence to justify that major investments in digital healthcare and a knowledge ecosystem will result in a significant return on investment and have a critical impact on improving healthcare delivery and health outcomes. This slide shows the ACTS COVID-19 Guidance Collaboration website. The site was recently launched in the last month. The URL is digital.arc.gov/COVID-ACTS. The purpose of the site is to help disseminate guidance summaries around COVID and support members of the ACTS stakeholder community to improve the development, dissemination, workflow integration, and use of living COVID-19 guidance. The goal is to make the knowledge supply chain more efficient and effective. This site also provides a workbench capability to help automate retrieval of and change tracking within evidence-based information. The site also provides a learning network and collaborative features to foster sharing of ideas and tools and solutions to improve COVID clinical guidance development and workflow integration. This slide shows the next steps for the ACTS initiative, which are first to create a detailed roadmap report that will be posted on the ACTS website URL shown on the next slide. We plan to release a request for information to gather stakeholder inputs around the recommendations from the roadmap. The RFI should be posted in the Federal Register later this month. We'll be operating and supporting the ACTS COVID Guidance Collaborative website discussed on the prior slide, and will perform a pilot effort or two that are now in the planning stage. And finally, an ACTS roadmap presentation was given recently to the ARC director that was well received, with recommendations from that presentation currently under advisement by ARC leadership. So that ends my presentation. If there are any questions, here's my email, and here are 2 URLs related to the ACTS initiative. Thank you, and I guess I'll turn it back to Rachel and Chuck.
Great. Thank you so much, Steve, for giving us that overview of that very important project. We do have one quick question I think you could address quickly, is how do people get involved in the different ACTS work groups?
Yes, they can go to the website I showed, digital.arc.gov/ACTS, and there's a link there to get to our support group, and we'll make sure that we respond to any of those requests.
Wonderful. Thank you. And I hear that we still do have our UK colleagues on the phone. There was some question about that. And if so, I'm going to direct a question. I think I'd like to direct one to Jeremy first. I hit on some of the COVID activities in a previous question. There were a number of questions about COVID and the types of activities there. Jerry Osheroff had mentioned about the kinds of synergies around COVID activities, in particular with the ACTS program, that that you might be willing to talk about. So Jeremy, you had mentioned a number of synergies in your efforts, and do you see any opportunities here with ACTS or COVID activities?
Yes, thanks for that question. I already mentioned the idea of a symptom checklist, which could be made available in primary care, for example. And that sounds rather trivial, but the fact is that the known symptoms of COVID have mushroomed since March, April. And it turns out now that there are really many more symptoms, including neurological and psychological symptoms than were previously imagined. Dermatological, it really affects every system of the body. And so the symptom checklist now is much longer than it used to be. So that's a good example of the advantages of computable knowledge, that you could disseminate and update that symptom checklist to all of the UK primary care team within seconds of that being validated. Another example would be some very interesting work that's happening at University College London, developing a risk assessment tool, a personal risk assessment tool for people to understand their own risk of, first of all, getting COVID, and then secondly, ending up seriously ill in hospital with it. And so initially, that really only took account of age, gender, and the presence of mild to moderate cardiovascular disease, diabetes, respiratory disease. But increasingly, that has been extended quite considerably. So now it includes ethnic group, it includes a whole range of other issues. And the latest, of course, would be frailty. That frailty, it turns out, is an independent risk factor for ending up seriously ill with COVID, independent of age and ethnic group. So that's another example of a simple algorithm which is becoming increasingly more complex. There is currently a web-based access to that through the University College London website. And there's a whole range of scenarios in which that could be used. But potentially, for example, it could be used by individuals to inform their personal behavior. You know, how risky is it to go out to the supermarket or to go to meet friends in the park? Well, I'll check my personal risk score and maybe that of my nearest and dearest and advise some of them to come to our meeting and some to stay away. So there's 2 examples. I hope that's helpful.
Yes, wonderful. Thank you. That's terrific. I'm trying to sort of group questions by themes, and I've got sort of 2 broad themes that I'd love to ask all the panelists to comment on. But first, I want to direct a more technical question to Philip about HL7 UK, and then perhaps Steve might want to comment similarly, but briefly on sort of the HL7 connection there. I'll read the question in a moment, and then just to get people thinking, I'd like to close out with everybody's comments, and I'll call on you one by one on a question from AJ Chen on how do you see the use of CBK in enabling dissemination of medical guidelines into clinical workflows? So sort of a broad question there. So first, Philip, Ed Hammond poses the question, since HL7 UK is a supporter of your efforts, would you comment on the possibility of HL7 being the SDO, Standards Development Organization, in which we create standards supporting MCBK as they are balloted in HL7?
Yeah, I certainly see it as an essential part of the infrastructure. Some work I've been doing in a local project, we've been using file libraries as part of the method of storing and accessing things like CQL algorithms. So it seems a natural home. I've only just learnt recently, for example, about the CPG on fire, which is something I want to get involved with, because that seems to me a very natural direction of travel. I do think, though, it's more than one SDO that's involved here because of the different levels of knowledge that we're talking about. I can certainly see fire being a central part of defining data structures and how we link in value sets. But then I think we also need to think about things like BPM for process models. So I was interested to see a couple of the posters describing scenarios where they're using that combination of BPM at the process level and fire at the data structure level. So I certainly feel that's a central part of how this will move forward, yes.
Wonderful. Thank you so much for that. And if we could go to Steve Bernstein, maybe you have a brief comment about the role of HL7.
Yes, no, I think HL7 is a key part of our overall initiative and of the roadmap efforts. Certainly EBM on fire and the CPG on fire and other HL7 initiatives are key standards efforts that need to come to fruition to help achieve the concepts of the digital knowledge platform and the knowledge ecosystem. And we've been also exploring at a very preliminary level the possibility of a sort of knowledge ecosystem based, fire-based accelerator group. But HL7, I think, is a key standards organization, and their efforts are critically important to moving the needle on this whole concept of a system.
Wonderful, thank you. And while we've got you on camera, I will also ask you to give a quick response, maybe even it's a soundbite, but a sentence or so about how you see CBK in enabling dissemination of medical guidelines into clinical workflows. And then I'll pose that same question to the other speakers. We've had a lot of questions related to that, so.
Yeah, no, absolutely. I mean, without getting computable guidance, it's going to be very difficult to get an efficient and effective evidence supply pipeline and supply chain into place. Dealing with paper and PDFs and trying to get living, updated evidence and guidance timely at the point of care will not really happen until we can get our key knowledge resources and artifacts into computable form and to be able to be delivered efficiently when and where and how they're needed. So it's critical.
Great, thank you. And I'd like to turn to Jeremy first and then Philip, and then just for heads up, Chuck, actually, I think I'll ask you Gunness's question to close us out. Philip?
Oh, for the same question. Yeah, I would sum up kind of what Chuck was saying in his introduction. We want to turn 17 years into 17 seconds in terms of implementing guidance.
Yeah. Wonderful. That's the big question, but I think when we get so in the weeds, it's nice to sort of step back again and see where we are. So, Jeremy, any thoughts or just closing remarks?
Thanks. Yes, I think what's exciting about CBK is that we can use it in so many different ways. In, for example, education, by using natural language generation techniques, we can generate text. If clinicians want text at the point of care, we can do that. But we can generate a long form or a short form from a guideline represented as CBK. We can also develop more appropriate text for patients and members of the public in different languages, using those same natural language techniques from the same CBK knowledge base. And then, of course, we can also generate alerts and reminders. We can populate checklists. We can generate a wall poster for clinicians if that's what they want. And often you go to an emergency room, you find wall posters there with a flow chart and a list of risk factors, whatever it is. We can generate all of that, preferably not on paper, though, because things change, as we've said, particularly around COVID. Things change fast. So that's exciting. We have a whole range of different delivery media and tools that we can give clinicians to help them manage better and safer.
Wonderful. Thank you so much for those closing remarks, and thank you to you and Philip and to Steve for your great presentations today. We do have just 1 minute left, and I wanted to just close with Chuck, who kicked us off in the panel. And you've gotten a question, a few variations of this, the most recent from Guinness Carew, on your thoughts related to gaps and challenges for P2D, for the different cycles of performance to data and data to knowledge. So I'll let you comment on that while my dog whines in the background here.
So I think your dog was whining in anticipation of my answer here. I'll try not to step too high on my soapbox, but I really think one of the things that MCBK is seeking to accomplish is to redress an imbalance that clearly exists between emphasis on data science and emphasis on what I would call knowledge science. So much of the time and effort and monetary investment on the part of foundations and institutes and other entities that support research and interventions to improve health has been on the data to knowledge side. And the importance of that cannot be understated. But it comes at the expense, in my opinion, of an emphasis on the knowledge to practice side, both the knowledge curation and management and its conversion to computable forms, as we've heard discussed just now, but also the implementation science, the practice change, which is a science all its own. So I think MCBK can be viewed, and this is another way of viewing it, as an effort to achieve a greater balance between data to knowledge and data science, and with knowledge to practice, knowledge management, knowledge science, and implementation science. I think if we really are going to move health to the next level, we really have to do an excellent job of making the D to K and K to P achieve a greater level of balance. Thank you for asking that question, Rachel, and I will step down from my soapbox now.
Wonderful. Thank you. Well, we're just a minute or so over, but I couldn't imagine anything more worthwhile than the comments and information that was shared with us today by you and others. So thank you so much to all our panelists.